Hi, everyone. So thanks for being here. Thanks for inviting us to share about our journey. I've really appreciated hearing from all of the speakers so far. It's been an awesome day. And Tanya, you and Alice were right on with that after lunch spot. It was fabulous, your presentation. So thank you for that. There's just so much learning that's gone on today. So Nikki and I are excited to give you some insights into how we've shifted our way of thinking and our approach toward fall prevention in really other areas of hospital-acquired harm as well. So this work had really just kind of started shortly before the pandemic took over our lives. So you're going to hear a little bit about how that's impacted us, and then also how we plan to regroup and move forward. So I'm going to start by giving you some background of our fall prevention team. So I'm pretty sure that many of you are probably familiar with this type of team that we had. Many may have even experienced some of the same challenges that our team was facing. Historically, and up through late 2018, our hospital had a very traditional fall prevention team. So our scope was really broad, kind of with the main general goal of preventing falls and decreasing our fall rate. But our focus is actually pretty narrow. Oftentimes we'd go down a path only to realize that we were preventing falls, but at a really high cost to the patient and the organization. So for example, at the cost of a hospital-acquired pressure injury or decline in overall function. And our interventions, although they were really well intended, weren't always the best sort of holistically for the patient and for the well-being of the patient. And we invested a lot of time and effort. We reviewed evidence, we tracked our rates, we performed root cause analyses, we did common cause analyses, went through several iterations of improvement work, but we still just didn't seem to be solving our problem with patient falls. So kind of in short, the projects kind of that we would take on really had low return. They produced really short-term effects. And so as our fall rates kind of continued unchanged, it was really disheartening for our team. We felt kind of more defeated, every time another fall would occur. And our team leaders were burning out. The team was just tired. And I definitely don't want to discredit their work. We had a lot of strengths. We definitely had a lot of wins, but the experience was just kind of generally exhausting. And we were struggling with kind of detecting any significant trend worth focusing on. And we're kind of driving ourselves crazy trying to slice and dice our data to give us some sort of meaningful direction. So that's just a little background on our fall prevention team.
Thank you, Hannah, and thank you, Anne, for that nice introduction. I've been a physical therapist for over 30 years, so mobility has been, near and dear to my heart, and trying to change that culture of immobility to mobility did start with me, around 2006, I would say. So if you attended this conference a couple of years ago, you may remember I presented some of this information with my colleague, Patty Puglisi, one of our clinical nurse leaders who was on the call today. I'll review where we were then, and we'll get to where we are now and where we're headed. So in 2007, just after I went to that conference about safe patient handling, we established a no-lift team. So an interdisciplinary team made of rehab nursing, patient safety, employee health. We called it Elliot on the Move because we wanted to get those patients up and moving and to address patient handling, trying to incorporate safe lifting equipment. Prior to that, as a PT, I thought everybody should know how to lift properly. And after that conference was a big wake-up call saying, we need to be lifting, we need to be safe ourselves and getting these patients out of bed using the right equipment. So the following few years, about 2008 to 2011, we started the process. We went through this whole process of establishing the need for lifting equipment, gaining the administration support and approval, implementing the program, procuring the equipment, educating the staff, establishing programs for education. So that all went on for several years. In about 2013 is when we expanded the group a little bit and kind of changed our focus to not just the safe use of equipment, but we want to be mobilizing patients. So it was about 2013 where we changed our name to Mobility Matters. And so I'm trying to start again to change that culture. I've told people before, I've been in my position for 18 or 19 years. And I'm retiring in about 14 years. And maybe by the time I retire, the culture of mobility will be ingrained in this facility. So that's my goal. I'm halfway there. And I think that actually we're like this, just this conference today is just really gets me excited about it. So I hope everyone is excited as well. And so our Mobility Matters team really started to, that's when we really started to make a lot of changes. We started recognizing that therapy and nursing talk different languages, and how do we change the documentation so we're all kind of talking the same language and understanding what each other are saying. And it was actually, I had learned, I think from an Exeter Hospital poster presentation many years ago, about putting a walker and a gait belt in every room. I think their initiative was walker, gait belt, and commode. But we went the walker and gait belt route, and we actually, again, administration support and approval and costs and all that stuff, and then education. But we got the walker and the gait belt in every room. And that, just having that equipment and making it accessible made that mobility better. And then we can continue to promote education regarding safe patient handling. And then the biggest thing we did is we established the Mobility Expert Program. And that program was designed as a train the trainer for nursing units and other departments so that they had a mobility expert or someone with extra attention to mobility that could be an on the floor resource, as well as someone who helped with continuing education. And we'll be talking about that a little bit.
So as Nikki mentioned, she and Patty had presented on our Mobility Expert Program at this workshop in 2018. The workshop featured Jackie Conrad from the Partnership for Patients, national subject matter expert on decreasing falls and other hospital-acquired injuries. It was local to us, it was well funded, and because we were really proud of our team, we wanted to show support. So Elliott was really well represented by members of both our fall prevention team, which was, primarily, nurses, and then also our Mobility Matters team, which had a lot of physical and occupational therapists at the time. So over the course of the day, we were exposed to a different way of thinking. We just started to gain a view from a wider angle, and we were hearing the message over and over again that keeping patients in bed with a bed alarm is ineffective at preventing falls or injuries. And at one point, I think Jackie actually directly challenged us to turn our fall prevention team into a team focused on mobility. And we were fortunate to already have a mobility team, but we realized that in some ways our teams were kind of competing versus working together. And so what I mean by that is we would have people, valuable human resources that were spending time and energy in one group without the capacity to contribute to the other. And then I think even worse, those that did participate in both teams were just experiencing burnout. So we did a bit more research. We learned this, that a structured multidisciplinary approach to mobility increases mobility. And so that's a given, right? But then also contributes to reduced length of stays. And so the lights kind of went off a little more for us here, because we all know that less time in the hospital is less risk for all other types of hospital-acquired harm, right? Not just from a fall, but infections, delirium, you name it. So this is when we kind of knew for sure that our teams needed to work together more, to row in the same direction, to look at our patients and their experience from a holistic perspective in order to prevent global harm to patients, not just prevent a fall at all costs. So we made a commitment to do just that. So here's a picture of our Elliott team at the Let's Join the Movement Towards the Movement workshop, I think almost 3 years ago now, right, Anne? So that's you can see here how large our group is. And then here's something that just highlights the tension that can exist between promoting mobility and preventing falls in the hospital. And this just really resonated with us and prompted us to learn more. This slide here is really just supposed to represent us learning more. So the more we learned, the more we realized that mobility really is one of the only interventions to objectively demonstrate an impact on reducing injuries from falls. So, with our changed way of thinking, we really just shifted toward a complete merge of our fall prevention team and our Mobility Matters team. And when we did that, The energy was high, the team was really hopeful, excited, and engaged, and the overall feeling was basically the opposite of what our fall prevention team had been experiencing. So that felt really good. I'm just going to pause for a second to read to you directly what we had kind of outlined as our project description when we were a newly formed team. So I just want to read this to you. This is what we kind of based our work on. Many patients walk into the hospital, but not as many walk out. Few hospitalized patients require bed rest, and most acute conditions do not necessitate immobility. Yet impaired mobility is a known issue for Elliott Hospital patients at discharge. Increased activity and mobilization during hospitalization can mitigate hospital-acquired functional decline, which we refer to as HAFD, so that patients can discharge and transition home optimally. This team will focus on root causes and countermeasures to reduce HAFD with the expected results: decreased falls, pressure ulcers, readmissions, and impaired mobility at discharge. Additionally, a reduction in employee injuries due to strains and sprains occurring during patient falls or mobilization is anticipated. An interdisciplinary approach to the issue of mobility may prevent HAFD. So it's lofty, right? But that's what we based ourselves on. So I just wanted to share that kind of verbatim with you.
So HAFD, it sounds like a funny little acronym, but it's really caught on for us. So we like to talk about HAFD prevention. And so you'll see a little bit later how we've addressed some of the education, but this is just an example of a story that, we had just kind of made up just to humanize our efforts. We offered this case study. Of course, it's not real, but it highlights how the actions at the bedside can impact a person's outcome and quality of life. So you obviously can't read this, so I'd like to just read it to you. Excuse me for my angelic voice. I hope you enjoyed my story. So this is a tale of two patients. We have Betty bedbound and we have Wanda walks a lot. So Betty lives alone in a mobile home with her dog Scooter. Betty usually walks with a cane, cares for herself, is able to take Scooter for his walks, and has her daughter bring her into the community for groceries and her other errands, and etc. once a week. Betty was admitted to the hospital on a Monday morning with pneumonia. She was feeling very ill and required oxygen, which she has never used before. She snuggled into the bed to recover. Since she was so ill, the caregivers had her use a bedpan the first day or so, and then a bedside commode. On Thursday, she was feeling better and wanted to sit up in a chair. When she attempted to stand up, she found her legs were too weak to get to the chair, and the caregivers needed to use lifting equipment to help her. Physical therapy was called to evaluate her and found that she was so deconditioned that she could not walk far enough to reach the bathroom. Betty was worried about how she would care for herself and who's going to walk Scooter if she can't. Betty was discharged to a rehab facility for recovery. Betty's daughter had to take in Scooter, who missed his mommy very much. Betty spent 5 weeks in the rehab facility, but was not able to return home independently due to the depression she experienced, losing her independence and the company of her dog. Betty moved into an assisted living that does not allow pets. So let's hear about Wanda's story, which kind of is parallel in the beginning. Wanda lives alone in a mobile home with her cats, Fluffy and Poopers. Wanda usually walks with a cane, cares for herself, is able to take care of her cats herself as well. She has her daughter bring her into the community for her groceries, etc. once a week. Wanda was admitted to the hospital on a Monday morning with pneumonia. She was feeling very ill and required oxygen, which she has never used before. So here's where the story changes a little bit. She was a little nervous about moving around as she had been so very ill when she came into the hospital. The caregivers encouraged her to mobilize so she would not lose her strength. Wanda used the walker for support and had a nice caregiver holding onto a belt around her waist to help her feel safe. She was able to walk as far as the hallway the first day. Each day, Wanda sat in the chair for her meals, walked into the bathroom with staff, and even walked a few times a day in the hall, each day a little bit further. On Thursday, physical therapy was called to assess her and found she was moving well and had not lost too much strength from her illness. She was able to return home with a walker and VNA services. Wanda was able to be with her cats and return to her independent lifestyle.
Thanks, Nikki. So our first official kickoff meeting was in October of 2018. The emphasis of our message to the team was high energy, creative out-of-the-box thinking, and also strategic use of our lean management system and our lean tools. And we focused on empowering the team members around the table in an attempt sort of to counteract the sense of deflation and defeat that people had been experiencing as part of our past prior fall prevention team. But we really emphasized that our main focus was not just to prevent falls, and we acknowledged that falls will still occur and may actually increase with an increased focus on mobility, but that our aim would be for injuries from falls to be reduced and for function to be maintained. So we wanted to show you this slide here just to demonstrate a couple of points. First, to highlight the thought that we put a lot of thought into ensuring that our team was well connected to the rest of our organization's workshops and quality and safety teams. And we knew that we couldn't work in a silo. So we spent some time really mapping out how we envisioned our work interacting with other teams and initiatives to optimize the structure and really to prevent redundancy. And this also demonstrates, though, that the team wasn't, in its infancy. And it really just drives home the fact that the birth of a new team, can happen, and it did for us sort of on pen and paper. So we just kind of wanted to show you where we started. And then versus here today, this is our official quality management structure today at Elliott. And you can see where our team fits in right there with that red arrow. So I'm showing you this so you can see sort of, how our team formed and was developed through kind of somewhat of a grassroots effort. It's now got its official place in our management system with a channel through which we can really escalate concerns and strategy can be deployed as well. So we just wanted to highlight that for you.
So if a patient walks into the hospital, they should not decline so much that they're unable to walk out. So how do we maintain that function? That's the big question. So where to get started? We needed a plan of attack. How do we organize such a big initiative and make sure all involved are engaged so we can succeed with positive changes? This is a fishbone diagram that's used a lot in lean management technique and other techniques as far as strategizing and studying your plan. This fishbone diagram is actually not the actual one. It's actually one from our subcommittee. But for the purpose of example, we used a fishbone to break down why patients don't mobilize in the hospital, or why is mobilizing a patient such a problem. So what are those barriers? So these were the majority of reasons we came up with. And you can see this slide is very busy, and it's busy on purpose. Our interdisciplinary team could identify so many reasons for not mobilizing. We had a hard time figuring out where to start. And a lot of these areas and issues involve so many different areas of patient care. So it's a big project to kind of take a bite out of. So we broke it down into subcommittees. So this is how, this is what was logical for us and how we felt we could affect change. And we broke up the committee into these subcommittees. So we had a large enough group that we were able to divide and conquer so we could efficiently use our resources to affect this change. We categorized the issues and formed 3 separate subgroups to be able to address more than one issue at a time. This allowed for everyone in the group to have ownership and to take advantage of all the different skills and disciplines in the room, giving everyone an active role. So we have the walk-in, walk-out committee. So this committee is addressing what is actually happening at the bedside, the availability of equipment, the daily flow of the patient care, and what clinical tools do we have or do we need to make it easier to employ and document. A messaging group. So this has to do with, educating people. We learned in our, that there's a lot of patients don't understand, or nurses don't understand, and these are the barriers we've been coming across. So how do we educate the staff? Where are the knowledge deficits? and what's the most effective way of educating them, as well as the patients and the families. You know, mobility is a new concept for them as well, because they all think you come into the hospital and lay in the bed to get better. And then our mobility expert program, which we had been working on for several years before the pandemic, but there were issues with the sustainability of that program. So we had some issues to keep, but we had continued to work on that as a subcommittee of this now new group.
So given the smaller work groups, we wanted to make sure that the large group meetings were as efficient as possible and didn't want to spend a lot of time and energy developing an agenda for each meeting when we could really be spending that energy, you know, in better ways. So we tapped into another one of our, you know, lean management tools again and developed a standard work for our large group meetings. And you can see that here. It's evolved over time, so this isn't exactly what it looks like now, but this was our original draft. But it should give you a sense of what to expect at each meeting. And with this agenda here up on display, another thing I just want to point out is the list of attendees. And for you all, you just see names here, probably don't know who we all are. But I think it's important for you to know how many roles and disciplines are represented. So you see myself and Nikki. There's also several names of clinical nurse leaders, LNAs. There's a pharmacist on our team, physical and occupational therapists. We have our radiology compliance coordinator, nurse educators, and we have a patient family advisory council member who I have to say has been incredibly valuable to this work and really instrumental in a lot of ways. And so this team meets once every other month for report outs because the subgroups are really active in getting work done in between meetings.
Yes, I also want to just put another stab in for that standard agenda. Everybody comes prepared because they know what the standard agenda is. They know that they have deliverables, and it makes the meeting run way smoother. And meeting every other month really gave us that time for each subgroup to work on their own things. So the walk-in, walk-out, so I'm going to talk a little bit about each subcommittee a little bit more. So the walk-in, walk-out, we call them the WEWOs, just because walk-in, walk-out is long. So they wanted to, again, they need to figure out what's going on the bedside. So this group did a few surveys. They surveyed bedside mobility versus the staff perceptions of how they mobilize and why and what the barriers are, how often they're mobilizing the patients, and also their relationship with therapy. And, you know, as all of you I'm sure know, there's always this wait for therapy to get patients out of bed versus why isn't the nurse getting them out of bed? So what are the perceptions there? We have our guy coming in with his IV pole. So hoping comfort level can be resolved with knowledge and accessibility. It's one of the things that to know what we want to do, but if you don't have the equipment to do, it's less likely to happen as well. So not just the comfort level of the staff, the comfort level of the patient, but those oxygen. And like we talked about before, the walkers and the gait belts in the rooms, awesome idea. But if nobody is paying attention and they don't get put back there when you go to look for it and it's not there, that's not going to help you. So you can see we have a picture here of what it looks like. We have a specific hooks for the walkers. They're in the same place in every room in all of the adult med surg rooms. There's a walker and gait belt behind every door. That was the best place we could find to put them. It was the only place there was really, but it works out. In the second picture, if you look all the way to the right, you can see there's an oxygen tank on an IV pole. And so it may seem like a very simple thing to you, but it actually, the rehab staff had identified several years before HAFD even started that was something that we'd like to do. Because if you have oxygen plus an IV pole plus you're guarding a patient, that's two people. You can't do that, you know, the only way to do that with one person, which a lot of people have skills, or even three people. So how can you manage that? So putting an oxygen ring on an IV pole, we actually got it done. It was the HAFD group, this WEWO group, that pushed it through up all the way through purchasing and our senior leadership team. And now they just bought a whole bunch of IV poles with oxygen rings, and they are given the direction to not ever buy IV poles without oxygen rings again. So, so we won that war. So The other thing that the WeWo group identified is that nursing didn't have a formal mobility assessment tool that they could use at the bedside. Having one would give them clinical evidence of the patient's abilities and guide them for what they can do with the patients, without having to depend on waiting for therapy or waiting for a second person because they're not sure. We decided to pilot a tool. This tool is called the Banner Mobility Assessment Tool for Nurses. I am not reporting any, but I don't own any stock in this. It's actually one of the tools that's used most around the country. And we haven't even tried it yet. So this is actually in our plans. So as we're coming back after post-pandemic shutdowns, we actually have come together as a group and been able to start making changes again. So we're hopefully going to be piloting this very soon on one floor, and then we hope to bring it to the rest of the house. So the next group, the messaging group. So here's another fishbone diagram, and each subgroup ended up doing fishbones so that they could study their own piece of the puzzle. So this is another one because a complicated problem needs to be broken down and again and from different perspectives. The HAFTE group determined that patients, families, and staff all lack knowledge and awareness of the importance of mobility during hospitalization that can contribute to hospital-acquired functional decline, or HAFDE. The aim of this subgroup of the messaging group was not only to educate, but to involve the patient, the family, and the staff in setting daily goals and plans to mobilize. Some initiatives this group promoted include motivational quotes to draw some people out into the hallways and give encouragement, distant markers painted in the halls, education flyers posted in staff areas, and tools such as a map of the floor and a way to track activity.
Yeah, so Nikki just mentioned the motivational signs in the hallways. One of the root causes or barriers that was identified by our survey and really reinforced by the input of our patients and our PFAC member on our team was the idea that patients don't feel like the hallways are their space. They actually expressed to us that they feel like they're almost intruding on the nurses when they approach the nurses station, or even just kind of spend too much time outside of their room or in the hallway. And so they are oriented to their own room when they arrive to the unit, but aren't necessarily oriented to the rest of the department, or sort of invited out into the hallways, and so they feel like they're sort of imposing. And so here, let me show you a couple of these pictures. So these inspirational quotes were added down the corridors of most of our inpatient departments. This was done through a partnership with our marketing team to really draw them out of their rooms and encourage them to continue moving. And a lot of our patients, we did find were walking further in the hallways because they wanted to get to the next quote and read it and see what it said, or see how many quotes they could get to. Of course, it's changed a little bit with the pandemic, but actually one of the sort of unforeseen benefits of having them up before the pandemic was that they really served as an uplifting sort of as uplifting messages for our staff during that time. But these are just some pictures there for you.
Yeah, so we had picked out about 20 or more quotes, and they put them randomly up and down the halls. So another initiative that came from the messaging group was employee education, and again, it's so hard. There's so much hanging up on the walls, and they're bombarded with education all the time. So we try to make them fun and interesting so that it'll grab people's attention. And here's just a couple of examples. The Betty and Wanda story was actually one of the first ones that we did. The one with the turkey is actually the last one we did, and I just put it together last fall during the pandemic because we noticed a lot more functional decline during the pandemic. I'm sure you all did, with patients having to stay in their rooms and so much less activity that, it was, we had a lot more decline. One of the things that we've tried is to have that branding and recognition on each on each piece of education. So they recognize HAFTE, HAFTE update. So they're going to recognize that flag that we put. And also, if you see the one on the left, 900 steps per day to maintain function. That came from one of the pieces of literature that we shared at the beginning. But the concept is if you need to walk 900 steps a day to maintain function. If you're walking less than 900 steps, you're going to be declining. If you're walking more, then you can start to improve. So that's another theme that we've had run through a couple of our educational pieces. And now here's an example. As Hannah mentioned, patients are oriented to their room when they arrive, but not to the unit. So how can we educate patients and families? How can you conceive of where you are? They were brought to that room in a stretcher. They have no idea the layout of the unit or what it looks like or anything. So we developed these maps. So when a patient is in the room, the maps provide an overview that includes where the nursing stations are, rest areas, the length of the hallways. And then on the back of the maps, we put an activity tracker that gives some education on why mobility is important. And it also gives a space for patients to track their own activity. We've put these in the backs of the welcome packets. We actually have 3 units that we made specific maps for that we do this on. And we're working on a couple more units making these maps. And again, we have that same branding. Actually, I don't know if we do. Also, I just wanted to also mention that talking about plans for mobilizing, another initiative that has just started so soon that I can't even get it on these slides is one of our CNLs is going to be leading her team in tracking plans for mobility. So when they huddle in the morning, they're supposed to have reviewed what the patient's activity level is and what their plan is that day to mobilize that patient. We're hoping that really will bring nurses' attention to the fact that these patients are going to mobilize. So it's bringing their thought process into their plan right along with when they're going to be giving them their meds and transferring them to somewhere. Oh, and sorry, Hannah, one more thing, the distance markers. So we have distance markers, if you could go back, sorry.
Sure.
That picture all the way to the left. We put little markers in the hallways every 10 feet, just so people can see if you come out of a room and you go and you come back, kind of how far you went. You can't always rely on the tiles on the floor. At the time we put them up, they didn't want them to be too intrusive. So they're right up there along the ceiling. Putting them along the floors or along the bottom of the, near the floor was one of the ideas, but because of doorways and hallways and things that you can't rely on in every 10 foot. So we ended up with them on the ceiling, so we have those as well.
All right.
So, and so the mobility expert group, now we alluded to it before, it originated from our previous Mobility Matters group. It was a train the trainer model to have mobility experts among the staff on every shift and every weekend, providing real-time assist in problem solving, also onboarding new staff, tracking annual competencies, taking care of the equipment. It was a lot for us to ask. We went through several PDSA or Plan, Do, Study, Act cycles with this. We started on one unit, we expanded it to several other units. We made changes for certain units. And we had a lot of successes with it, but we also had some difficulties with sustainability. The ownership of it and the attrition and retention of the mobility experts, and as well as what our hopes for the expectations of their duties were and what they were actually able to do in their roles as an LNA and RN on the floor. So we had, so we were addressing those issues right when COVID happened. Work has resumed with a bigger role from nursing education, and the unit and departments are involved. And we're also going to be involved in nursing orientation starting in June, and they're giving us a great big chunk of time, like 75 minutes, to introduce this concept to all RNs and LNAs starting. So we're gonna have fun with that 75 minutes of information we're gonna share with them.
So we thought it was worth mentioning that while the team's not any longer primarily focused on fall prevention directly, there's still a team, our safety practice, collaborative practice team, that provides oversight for falls throughout the hospital. That team monitors falls as part of our preventable harm score and would take action and has on any unfavorable trend. But then we also have unit practice councils that have local level responsibility for their outcomes, including falls, and they would receive support from either our CAFD prevention team or the safety CPT as needed for more global initiatives. So that's sort of how the oversight and improvement work remains kind of focused directly on falls. And we also kind of wanted to let you know that as a team, we have reviewed cases for learning opportunities as well. We thought we'd share this, just one example of an event that occurred in our radiology testing area that had some good learning involved. So in meeting with the team after the event, we wanted to make sure that handoff of the fall risk was being provided routinely for patients that transfer to radiology for testing, and that when we're talking about handoff, we're not just communicating that a patient is at risk for fall, but also why, they would be considered at risk for fall. And at first, their team just didn't really seem receptive or interested in this. And we couldn't really understand why. We kind of felt like there was a barrier in our conversation, and we were trying to figure out where that was coming from. And then finally, when we showed them what our nursing risk assessment questions actually look like, it was kind of like a light bulb went off for them. And we learned that they really hadn't thought that there might be different reasons why a patient would be at risk for fall. They said generally that they would just they could tell by looking at a patient and determining if they looked elderly or confused or frail or had some sort of other overt visual cue that they might be at risk for fall. And they just had never considered that something like a new medication or a medication adjustment could put an otherwise fit and healthy person into a high fall risk category. And so to us, this seemed obvious because it's been a given in our world, right, as clinicians. And we just assumed that their team had been educated and knowledgeable about fall risk, and it just wasn't the case. So after we got past that, we were able to move into a partnership and really start some improvement work with their team, which was exciting. Putting plans in place for education, then also starting some PDSAs for improvement around transport, modifying the waiting room layout and processes and handoff. And that's another thing that we had had going on right when COVID started. So that's something we're looking forward to picking back up as well. We're having babies born in our hospital today.
Sorry, I think it's worth sharing that our radiology department actually sent many people through the mobility expert program. So they have mobility experts in their radiology areas and all of our outpatient and inpatient departments.
Yeah, thanks, Nikki. That's a great point. All right, so we thought that you'd probably be interested in outcomes. We found from the beginning it's been an extremely difficult topic to measure or to demonstrate value. We struggled from the beginning. And then, of course, over the last 12 to 15 months, we've faced unforeseen factors that have complicated things even further. So a lot of our improvement work kind of halted as our world turned upside down for a little while. In looking back, though, there has not been any significant change to our falls data, regardless of what angle we really look at it. So the same departments contributed to the top 80% of all falls pre and post change. But we have seen a slight, although it's insignificant, we've seen a slight decrease in the percentage of total falls that resulted in moderate or major injuries. So we've had more falls with only minor or no injury. And to me, this decrease is really just kind of a good indicator telling us that we didn't go in the wrong direction, which is validating, but not significant. We've also seen an increase in assisted falls without injury. So that wasn't one of our top 3 categories reported pre-implementation, but it did jump to one of the top 3 categories of falls post-implementation. So assisted falls are telling us, that there is a staff member with a patient, and it may even be during ambulation, we would hope. So these assisted falls without injury would be ones that we might celebrate. And then I can also say that we've had a reduction in serious reportable events related to hospital-acquired pressure injuries and falls from calendar year 2019 to 2020. But again, that can't be directly linked to this team's work. We've had other improvement work going on around pressure injuries, and then of course the countless X factors that we've kind of faced throughout the pandemic, including our extreme census variation, a period of time where we had virtually no elective surgical population, and then of course all the disruptions that COVID has caused around staffing and processes and practices. So it's just really hard to look at the year 2020 and know sort of what the contributing factors were there. But we did experience a significant decrease in staff sprains and strains related to lifting and mobilizing, as well as decrease in variation. So this is really exciting to see, likely, I think, in part, at least, a result of the team's work. So I see we just have a few more minutes here. We'll wrap it up. Here, we just kind of wanted to show you how the pandemic really forced us to pause. And one nice thing was that it really kind of gave us an opportunity to reflect on everything that we've done in such a short amount of time. And at our first regathering, we revisited the relevancy of our previous efforts and aims, considered the past state and our current state, and we developed a plan to move forward and pick up what we think is really important work. So here, this is an A3 where we reflected on what worked well and what our plans are moving forward. So on the left-hand side here, you see our reflections and learning from our past. And then on the right-hand side is our action plan mapped out for the coming year. So we're excited to get ourselves back on track.
Right. So to summarize, as you all know, I'm sure you're familiar, we're always working on continuous improvement. So as Hannah just said, we've picked up where we've left off. Picked up not where we left off, but in a different place, and try to figure out how we can get moving. And we're lucky that Elliott Health System has provided us with these management tools, and your facility may have different management tools, but using those tools to help really understand the problem and define how to approach it in a systematic manner, I think made all the difference with this group. I've been on the Falls Committee for almost 20 years, and this is one of the best things we ever did with the Falls Committee, was to combine it with the Mobility Committee. So as we discussed, we'll be planning to pilot the BMAT, or that Banner Mobility Assessment Tool, which we hope will engage the nurses and bring greater awareness to patients' abilities, and then roll out to the whole house as able. We're working on an interactive digital forms of education in lieu of the live classes. Though it's not ideal that we might not have the full classes we had before for education, we're hoping to reach more people with this digital platform. And we're changing mobility experts to mobility champions and trying to move more into that nursing model, so that the nursing units will embrace those positions and make it part of their routine, and less of a burden from the outside making these units do it, but more of an ingrown education for themselves. And as everybody alluded to, starting with Marie this morning, and thank you, Marie, for that. And if you want the East Coast, Elliott Hospital, and obviously you can see several hospitals in New Hampshire are really nice and doing great work. So we'd love to see you here. But we're working on that dementia-friendly, age-friendly facility as well. And we're really feeling like, especially after today and hearing all this, these other perspectives, that, this work will go right in with our other work to be dementia friendly. But, thank you for all of thank you to Anne in this presentation and this, it seems like all of these talks really went really well together, and we're hitting all of those 4 M's as a total. So thank you to the presenters as well. Any questions?
There was one question about the reference, if you could offer the reference for the chart where it was like the 900 steps per day.
I want to say that's one of the first articles that we had on our slide.
Okay, so
I could go back and check, and it's one of the first 2 articles that Hannah shared at the very beginning.
Great, thank you.